Welcome, everybody. On behalf of NHS and the Planning Committee, I would like to welcome you to Health Insurance 101, Back to Basics. My name is Marla Feinstein. I'm the Senior Healthcare and Policy Analyst with NHS. But before we dive into the session, I would like to thank our sponsors, CSL, Genentech, Grifols, Hemophilia Alliance, Novo Nordisk, Pfizer, Sanofi Genzyme, and Takeda. And the platform is amazing. I'm really very happy with how it turned out. And I wanted to also remind you about the NHF Conference Behavior Guidelines, which you can find on the conference platform on the left. So this session is, again, the pre-con, right? This is what reminds everybody what's at stake and what health insurance is all about. And with that is making sure we understand, so we're all on the level playing field. A lot of times some of the terminology changes and, all I have to say is 2020 has been quite a year. So it's always good to remind everybody what we will be doing. With that, I'm going to kick things off and with the actual presentation component of this. So when we think about health policy, what do we think about? We think about some of the basic questions that you need to understand in order to move forward, right? What are the issues you're having? But most of all, does it improve access to healthcare? Because what good is any policy should it not improve access to healthcare? Does it work to improve patient outcomes and lower the overall cost of delivering healthcare? Understanding the goal of how healthcare is delivered and financed is basically the overall key to understanding how we got here and what is the issue and why are people having issues with respect to access to affordable healthcare. Okay, but this is, the back to basics session. So we all want to remember that what is health insurance, okay? In its very basic and most simple form, it is a contract. It is a contract between an individual and an insurance company. That's the same as any other contract you sign, right? So what happens with health insurance is that you pay a monthly fee, right? Which we all know is called a premium. Okay, so, and then the insurance company agrees to pay all or part of some of these expenses, right? If you have 100% coverage, it's going to say it's 100% covered, right? And the difference is, if you have a group with membership fees, every group pays in. An existing family, an individual, someone with additional healthcare needs are paying into this group coverage, okay? So we all pay into the giant pool, and then the claims are paid. Therefore, everyone within this system has healthcare coverage, in theory. The ACA did one of many really fantastic things. One of the major things it did is it established what we call 10 essential health benefits. These are just broad benefit categories, right? These categories include everything, right? What does it mean to include everything? Well, that's a little bit different, and we'll get into that in a second. But all plans must include these 10 categories. Okay, so you have prescription drug coverage, emergency services, hospitalization, lab, maternity, preventative wellness, all these different kinds of things, right? But what's not included in this is some of the specifics, right? And what do I mean when I say some of the specifics? I mean the duration, right? Can you have an unlimited number of occupational and physical therapy visits? No, right? Instead of restricting the dollar limit, because we all knew that that was part of the ACA, that you cannot have an annual limit on an annual dollar limit. But what we know is they can limit the number of services or the scope of services. So it means that you can't go likely to any pharmacy you can. You have prescription drug coverage, but the prescription drug coverage may not be what you think it should be, right? And these are all important, right? And it's important because you need to know that these categories that you see listed on your screen matter. So what the federal government did, what the ACA did, essentially was create something called the floor, okay? That is the bare minimum under law that they that insurance companies have to provide for enrollees, right? You can go above the floor, and in fact, many states and many policies do in fact go above this floor, up until what is called in health policy or basic econ, the ceiling, right? So somewhere in between is what you're getting. In addition, a lot of state marketplaces model their EHB with respect to their individual state makeup, right? So this is also different. Meaning what you have in Montana is not necessarily going to be the same scope of services that you're going to have in New York. And that's an important underpinning of this, right? What's also important to understand is insurance types. Now, this can get really, really ugly, really, really fast. So when I like to introduce insurance types, I take it super basic, right? Think of it as two parts: private insurance and public insurance. There's only two flavors, okay? Within those two flavors, there's a lot of different subcategories within there, okay? And we'll go through those in a second, but I want everyone to understand that there's a difference between public and private insurance. First up is private insurance. A lot of this comes down to who's paying for what and who is paying the bill, right? And this will also help you understand why payers make some of these decisions, right? These decisions are not necessarily made in a vacuum, right? So private insurance is something that you have through, it's either called job-based or employer-sponsored. You can have two flavors of this kind of ice cream, if you will. And the first flavor is what's called a fully insured plan or a fully funded plan. A plan in which the employer contracts with another organization to assume the financial responsibility for the enrollees and for all the incurred cost. A self-insured plan is a little bit different, or a self-funded plan. They're basically two of the same thing. It's a type of plan usually present in a larger company. If you work for Staples, if you work for Apple or something like this, but it doesn't have to be a Staples number of employees kind of thing. It has to be just a large number of employees, where the employer themselves contracts, where they collect the premiums from the enrollees and take on the financial responsibility of paying employees and dependents' medical claims. This is a huge distinction here, okay? And the reason I say that is because it matters where you go for help, and we'll get to that in a second. So the employers can contract with anyone for the insurance services, right? They can contract with someone for enrollment, for claims processing, provider networks, or even a third-party administrator, or they can administer themselves. Lots of times a self-insured plan will actually go with somebody else because they're like, hi, I'm Apple. I design hardware and software. I probably shouldn't be designing people's healthcare, so we're going to do it separately. Self-insured plans, the big difference is, and you'll hear more about this in later sessions, and as a reminder, this is just to prep you and get you ready for some of the later sessions, is that self-insured plans do not have to follow state insurance rules. They're bound by something called the federal rule known as ERISA, which is under the U.S. Department of Labor. Okay? That's going to be important in a moment and in later terms, because if they're bound by ERISA, they don't necessarily have to follow all the rules, which then brings us, you can purchase individually either on or off the marketplace. What is on the marketplace is if you go to healthcare.gov or your state-based marketplace, that means you can purchase a plan for yourself or your family or your spouse or partner. You can also buy it off marketplace, which means you can go through a broker, okay? And I will not go into the differences between on and off marketplace right at the moment, because that's a much deeper conversation, which then brings us to public insurance, right? Public insurance is a little bit different. Medicare is a fully federal program, okay? That means the federal government runs the program. Medicaid is a joint federal and state program, meaning the federal government sets the rules and the states modify them to reflect their population, because the idea is that your state knows better how to serve your population, meaning any given state knows that what their constituents need and how to respond accordingly. The same is with CHIP, which is the Children's Health Insurance Program, right? Where states can add to it, and the federal government, again, sets the floor. And finally, we have TRICARE and VA. Okay, these are for active and veterans military benefits. Technically, those are public or federal health insurance programs. So if everyone is clear on what we're sort of dealing with when we think about public and private, it matters because the type of coverage matters where you go for assistance. And why is that important? Well, because sometimes, in my experience, is that people are often angry at the wrong people, right? And so if you have a self-insured plan, right, a self-insured employer plan, and you're arguing with, let's say, Aetna, I'm just picking Aetna, nothing wrong with Aetna, but it's just an A, okay? And you're arguing with Aetna, but in reality, it's your employer who's actually paying the premiums, right? So it's your employer who's contracted with Aetna, so you need to think about a different strategy, right? And ultimately, it's regulated by ERISA, so therefore, it's a federal program, so you have to go through the Department of Labor, okay? And if you have a private or fully insured employer plans, those are regulated differently because, again, these are bound by state. So you can go to your state Department of Insurance. And public plans, right, be it Medicare or Medicaid, VA, you have to go to their respective websites or their program managers, right? So if you have a problem with Medicaid, you call Medicaid, okay? It doesn't matter who is administering the Medicaid plan themselves, but it matters with respect to, are you contacting the right agency or the right person at that agency to help solve your problems? Most of all, insurance is all about finding the balance between what you can pay and what you need and what you want, right? It's a very, very, very delicate balance, okay? And I see that because it forces people to think more so about what do they need, right? What do they need access to, okay? What do you need? You need access to your hemophilia treatment center, right? You need drug coverage, you need your primary care physician, right? But if you have a family, what does that mean? You have to consider all of their physicians as well. And this is sort of important because sometimes we get a little bit lost and we're always worrying about the bleeding disorder coverage, only to then later find out, oh darn, we didn't think about some of the other things that we have going on in my family, in my situation, or whatever, right? So the tools that insurance companies use are called networks, right? So you've heard in-network, out-of-network, right? Those are pretty common terms, right? But you have to consider who and what you want inside that network, okay? And that has to do with the network type and size, right? In general, the smaller the network, right, the cheaper the cost, right? Because it's saying everyone within this very small window is included, okay? The broader the network, the wider the network, the higher the cost, okay? So if you want to be able to choose among providers, you're going to have to pay more. There's no way in our current health system to sort of control for that, right? Meaning that quite often you just have to pay more if you want more bells and whistles, okay? And I understand that networks are not necessarily the same as bells and whistles, but for the purposes of an insurance company, they kind of are, right? Because they're dictating who you can see and where. And we'll go through a little bit more of that in a bit. So it may even have some out-of-network coverage, right? If you want to pay more for out-of-network coverage, you can. You do have that option in some plans. Other plans, for example, may not be covered at all. There's nothing you can do. You can't sort of control it, right? If you're choosing a network that clearly and very explicitly says we do not cover any out-of-network services, the insurance company will not reimburse for any of those network out-of services, Okay? A lot of times, some of the more fancier plans, or what they used to call Cadillac plans, means that you can have that service, but they're not going to cover it at the same rate as they would an in-network provider. So then you have to think about what is the type of the plan you're considering. And all of this is a giant word salad, and we'll get into that in one brief second. But what I want to say is that you have to think about how they're defining the plan, meaning how the insurance company is defining their plan. And the different prices are reflective largely of the networks, right? Largely of the type of services that you can have access to and the type of services that you need, right? And even with all of this and all of the planning, you have some issues that you need to sort of determine and work out for yourself, right? And this is where a lot of people sort of stumble, because even with investing all of your time and energy, then you're stuck in sort of this plan, what I call a planned word salad. So let's sort of look at some of this planned word salad, right? One type of plan that you often hear about is a high deductible health plan. What does that mean? It has a higher deductible, but a lower monthly premium, okay? That is a different type of plan, meaning you have to meet the deductible first. There's no question that you have to meet your full deductible first before the plan begins to pay, under any circumstances. You can also join a high deductible health plan with a health savings account. Okay, and these are more prevalent now, and we'll have a later speaker who's going to talk about how the market distribution is, so don't worry about that, but worry more about what you're getting, okay, what you want. And I forgot to add, from the previous slide, I forgot to say, if you want something which is not on the list, you're going to have to pay. It's either not going to be covered or it's going to be covered at a much higher charge. The inverse applies to things which are considered in-network. Okay? The next type is something called an exclusive provider, an EPO plan. The EPO plan is a managed care plan. That means under no circumstances will you be having out-of-network coverage. Period. If you have in-network only, if you have an EPO plan and you're seeking out-of-network coverage, you're going to have to pay for that. Then there's something called a POS plan, or a point of service plan. For these types of plans, you need a referral from your primary care physician, and you're going to pay less for in-network provider. I want this to all be pretty clear, okay? And there you have something called a PPO plan, or preferred provider organization, which means you pay less for in-network, but you also have the ability to use some out-of-network services with either a referral, or you're going to have additional costs, right? It is extremely unlikely that anyone will cover in-network or out-of-network at the same cost, because then the whole premise of a network wouldn't be applicable in this scenario. Then you have something, traditional HMO, right? HMOs got a bad rap when they first came out, but they're actually not bad at all. They tend to limit coverage to in-network, although not as bad as an exclusive provider organization. But in general, they won't cover out-of-network, but focus on more of this holistic approach, right, of an integrated care where they're focusing on prevention and wellness as well. A lot of it also comes down to what it is you're willing or able to pay. Okay, costs. There has been a ton of discussion. You hear it all the time if you turn on the news, if you turn on anything, a discussion about cost, right? And affordability. Because these are very, very serious concerns, right? We all know that the cost of health insurance are increasing, right? And while wages remain stagnant, but you can't have something cost more while your wages don't proportionally change, which is a problem. And similarly, you can't expect your employer to pay in more if your wage, like, it's a whole complicated calculus with respect to affordability. But lots of affordability has to do with what your personal preference is, right? What your personal comfort level is. Me, personally, I would rather pay more in premiums, okay, and have a lower deductible. So I don't have to pay upfront the highest amount I'm ever going to pay. That's just my personal preference. You could spread it out over the year, and that would be what I would choose, right? But some people prefer more upfront costs, right? Let me just pay my 10 grand now, and we're done, and then have the insurance cover it. But what's important to understand in addition to that is not only the affordability question and the preference question, is the maximum you're going to have to pay out of pocket, okay? That maximum out of pocket is capped annually. That annual out of pocket max is for individuals and families. It changes every year. It's increasing ever so slightly, kind of on par with the way premiums are increasing, so proportional with that, but it doesn't include the premiums. So when you think about your maximum out of pocket, the allowance for an individual, which is I think $81.50 for 2020, which is a moot point now, but that's for the individual, okay? And I say that because these are your costs that you are responsible for. Anything which is included in the maximum out of pocket, which includes your co-pays, your co-insurance, and your deductible, is what you will have to pay out of pocket, right? It doesn't include your premiums. So if you're paying $100 in premiums, you have to also think about what are the other costs I'm paying. I'm paying co-pays, I'm paying co-insurance, and if I have a deductible, how high that deductible is, I have to pay that. Then the question becomes, well, my son reached his out-of-pocket maximum, but what about my family? Well, your family has a different out-of-pocket maximum. So you can have individuals within your plan reach their out-of-pocket max. That means that their services are then covered. But what do you think happens to the family? Does the family then have to still pay out-of-pocket? So you have the son who's reached his out-of-pocket max, and the mom needs to go to the doctor. That is something which people find somewhat surprising because it's not always super clear. It's not super clear what applies, right? But what you need to remember, these are things that are included. Co-pays, co-insurance, deductibles. It is not allowed to go above the federal out-of-pocket max. It's called MOOP, which I'm sure you guys enjoy the word MOOP, which stands for your maximum out-of-pocket. That MOOP is after you hit that target, the plan pays 100%. That doesn't mean if the mom still needs to go to the doctor, hers is covered at 100%. Nope, that's just the plan. Everything changes. And what does that mean? The plans change. They can and will. But the individual situations, right? Let's think about COVID, and we're going to have an excellent presentation later today from someone regarding COVID. But if you've lost your job, right, that is a personal situation that has changed, right? As a result, your income has changed. The point is, don't be assumed that the plan is the same because you had it last year. Okay, even if you had an Aetna PPO last year, do not assume that Aetna PPO is the exact same coverage you're going to get for this year because the plans will change. Review it annually at a minimum, okay? Because quite often they sort of sneak in, some little mid-year plan changes, and you're like, what? I didn't know this, right? Well, they probably sent you a letter, first of all. Open your mail. That's and vote. Those are the two things I always tell people. Open your mail. Because they did probably put it in writing in either snail mail or in email. And also benefit design changes, right? A new drug comes to market. If you're looking at an old plan, an old drug list, you can't really assume that drug, of course the drug's not on that list because it didn't come to market yet, right? So you have to really sort of think about some of these changes and how insurance companies will deal with these changes, right? And similarly, you have to think about the medical benefit and the pharmacy benefit. Income changes, okay? Income, most people don't realize that the overwhelming majority of people on the marketplace qualify for subsidies. Okay, subsidies go up to 400% of the federal poverty level. Okay, the federal poverty level changes each year. Similarly, Medicaid, most people don't recognize how their income has changed or how their situation has changed and what has changed, but what does that mean, right? And did your state recently expand Medicaid? Because let's not forget, a lot of states were quick to jump on that bandwagon once they saw the clock was running out. So if you live in one of the 37 states that did expand Medicaid, you can go there and see what their qualifications are, right? So all of these things are important to understand, because even though you think, oh, it's just $100, it was only a cost of living increase, it was only this, or I didn't get a raise, or whatever it is, you may be eligible for things that you're not aware that you were eligible for before. And I say that especially now, because a lot of people were recently laid off or furloughed, and their income has in fact changed. But what's also important, I want to note right now, is that while subsidies are available, those things are only available for marketplace plans. Open enrollment comes every year. This is why we have this conference now, okay? We have it now because you have to pay attention to deadlines. Job-based or employer-based coverage has different deadlines than state-based marketplace. Marketplace coverage also has different deadlines. So if you're one of the 13 states which operate your own marketplace, soon to be Virginia, props to my Virginia friends, they can also set their own parameters in terms of what they can, how long to have their open enrollment period. I believe the special enrollment period in New York and actually in California is still open in response to COVID. And again, signed policies are like contracts, okay? You wouldn't just go and be like, yeah, I'm going to break this contract and see how you respond. No, right? Without something that qualifies, right, a qualifying life event, birth, death, marriage, these are a standard set of things that change that may, change your status and what you have as an option. California also extended their subsidies as well, up to 600% of the federal poverty level. So if you buy a marketplace plan in California, that's up to 600% of the federal poverty level to receive subsidized coverage. It's all to sort of say that there's a lot going on, right? There's a lot going on, and no one is expected to know exactly which state does which, right? In general, we all know the outliers, right? In this case, it's New York and California who are the outliers. It's impossible to know unless your state runs through healthcare.gov when their exact timelines are for open enrollment. Okay. And I did reference our health insurance toolkit, but I'm just going to say it again. What I want to say is that we have outlined a number of common questions. What are the general questions you should start thinking about when you think about some insurance stuff? Your annual premium, your monthly premium, what is it that you're needing? Your total out-of-pocket costs, the networks, the composition, would you want things in or out, right? I personally enjoy the freedom, and I'm willing to pay a little bit more in premiums to have out-of-network coverage. Are there limits on the number of services? Do I have out-of-state coverage, right? A lot of people have, especially now, I don't even know, right, like how that's working out, but a lot of people go, well, I live in Florida 6 months and in New York for 6 months. You better make sure whatever plan, is being looked at has that coverage, right? Has that very specific out-of-network coverage. Questions we've considered, right? Factor coverage. Is it medical, pharmacy, or both? It's very hard to see. You have your choice of specialty pharmacy providers, right? You know for a fact that a lot of plans can't contract solely with their in-network pharmacy provider, with their subsidiary, right? NHS position has always been, ideally, a plan should have more than one specialty pharmacy provider, ideally 1 340B and one other, right? That because we want people to have the ability to access the integrated care pharmacy. Do you need a referral to the HTC? I had an interesting situation come up with someone who was having issues, and I assumed naively that it was the drug that wasn't covered. Turns out the drug was covered, no problem, no prior auth even needed, which was bizarre in a number of different ways, but he couldn't get a referral to the HTC. The HTC wasn't in network. Okay? These are all problems that have come up over the last year or so. Do copay cards count toward your out-of-pocket or your deductible? We're going to hear about third-party premium assistance tomorrow, and we'll hear more about, do they allow that, right? Or is your plan allowing third-party premium assistance? And which services need prior auth, and home nursing, is that a thing? But everyone always worries about factor. And what we know over the years, it's hard to pin down, okay? And when I say it's hard to pin down, I mean whether it's covered under the medical benefit or through the pharmacy benefit. A lot of the confusion comes from when you call and you ask, like, is factor covered? And they're like, I don't understand. Like, what do you mean? Like, it can't be a medical benefit if you're getting it through the pharmacy. There's a lot of education that NHF has been doing, and you'll hear more from my colleague Colette tomorrow about that. But getting them to understand that, you know, having some of the people on the phone that you often call, right, what that is. What is the information that they're dispensing, if you will. But it's important to know that there's nothing wrong with a prior auth, okay? Right? I get it. I'm speaking to providers, and I can't physically see your eyes rolling right now, but I know it is painful, and we have a session just for that. But, right, most insurance will require PA. Or prior authorization, because they need to do their due diligence and check their boxes with respect to what it is they're wondering about, what concerns they have about people accessing the drug, and what are their conditions, and what, you know, are there limitations on any of this. And the next thing is one of my favorite things, which doesn't get enough attention, which I refer to all the time. The ACA established a summary of benefits and coverage. What does this mean? There's a lot of information here, right? So when I say, hey, can you pull up the summary of benefits and coverage when I'm trying to help somebody, I can look and see here, this is the pharmacy, right? I'm in the pharmacy section. These are all little hyperlinks, okay? They do tell you the information. It is just tedious and often painful to access that information. So I like to remind people that this exists. It allows you to easily compare what's in and out and what your costs are. Moreover, it does detail, if you have specialty drugs, how they're likely covered within there. We recently updated our personal health insurance toolkit. It is online only, right? Because God only knows what's going to happen later. We decided online only was the best way to get it out there. One of the most common questions I get asked, and I imagine a lot of you guys get asked, is, which one should I get? I'm going to tell you 18,000 reasons. Okay, really not 18,000, but maybe like a handful of reasons why you should never sort of give that explicit advice, right? Because you may not have a complete picture of that family. You only see the child, or you only see the adult. You don't know exactly what is going on, like, oh man, I forgot to tell you, my daughter has asthma and I need this. Okay? Right? These are all different sort of questions that people come to you after you've given them your advice, right? You may never have a full picture, nor would you actually want a full picture of the family's finances and assets. All of these things need to be uploaded, right, if you qualify for certain federal programs, right? And I cannot tell you, I've said this before, I cannot tell you what is affordable to you versus what is affordable to me. Similarly, you should not tell me what's affordable, right? So it's impossible to say, like, well, it's $5. And then they look at me like I don't have $5, right? And so you shouldn't project that onto people. And that's why, in general, you shouldn't sort of say what they, you know, well, it is affordable relatively. Okay, and do they have access to other insurance options? Sometimes people get stuck or forget that marketplaces exist, and you can easily shop for a plan on the marketplace and see what your options are. So you can tell people all of their options. You can tell people what they need, but you can't make them choose, nor should you choose for them. But then when they ask you to come, when they need help, it's an icky situation. This is all to say, look, you're going to hear a lot of talks over the next couple of days about different parts of what's changing, what's not changing, when to enroll, what you need. But what I strongly encourage you to share with whomever you're helping is that do not buy a plan just because it costs less. No matter how many times I say that, when you're sorting by price, you have to remember that insurance companies are also sorting by price, right? That we rise to the top. They know that they're there, right? They know that the patients are there. They know that the families are there because there's a whole terminology, which Colette will discuss, about high-cost claimants, right? So similarly, don't buy just because it costs less, right? Don't buy it because your broker likes it. Don't buy it because of this. There's a million things. But only the patient, family, caregiver knows their needs. You do not. As much as you think you do, you probably don't, right? So therefore, when someone calls you and it's Friday, it's, I don't know, 5 o'clock, and they're like, but I have to pick it by midnight. There's no way that they found out at 5 o'clock that they had to pick it at midnight, okay? They knew before, so do not wait. And also encourage community members that you interact with each and every day to not wait till the last minute to shop. Because when you're pressured and when you're calling and they're asking for advice under pressure, quite often it's just sort by price and we're good, right? And you're like, I wish you had yesterday, or last week. So the point is, be a good consumer and encourage them to be good consumers and to do their homework, because now more than in previous years, it's a tough call, right? We don't know a lot of things about what's going to happen. And we'll hear a lot about that next. Hopefully you guys got a little bit more out of this, so some of these terms are going to be familiar to you when you hear them next time. And some of this hopefully jogs some of your memory, and you can ask questions to some of the other speakers at subsequent sessions. And with that, I'm going to end this, and I will see you on the other side.